Dear esteemed audience, thank you very much for joining today from across the country. Trauma as an ED physician has always been very close to my heart, and I thank Dr. Raja Durai to give me this opportunity to speak on my favorite topic. At its always in decent practice, and we'll take that home as fresh from oven. So let's go ahead. This man doesn't need any introduction. A big shout out to Professor Karim Brohi, a pioneer in trauma resuscitation. Have seen many lectures of his, read a lot of research and papers published by his team and himself. So if you find anything familiar or similar in my talk, he's the inspiration behind it. Well, on a fateful night in Nebraska in 1976, a plane crash changed the way the world looked at trauma care. Dr. James Steiner lost his wife and almost lost his children. That night, he figured he could give better care in the field than was provided to him by the health center to his children and him where they were taken to after an accident. It sparked a flame in Dr. Steiner's, and he made a resolve to create a standard of care all trauma patients should receive, no matter where they are. And that's how the first, in collaboration with Lincoln Medical Education, the first ATLS course was delivered in 1978. It was further adopted by the American College of Surgeons in 1980 and later spread throughout the world to be taught in more than 80 countries. This picture is from the first ever ATLS class. Care. But the strict adherence to the approach has been questioned in recent times. Let's look at this case. A 50-year-old male who was a construction worker has presented to your emergency with a history of fall from the second floor of a construction site. His GCS in the field is 12, and in emergency department, you evaluate this patient as per the ATLS support protocol. His vitals are as follows. Respiratory rate you get of 28 breaths per minute, oxygen saturation 90% on 100% oxygen. Heart rate is 115 approximately beats per minute. Blood pressure is 103/80 mm of Hg, and temperature is around 98.8 degrees Fahrenheit. His airway is assessed to be patent, and air entry is decreased in the right side of the chest. A focus assessment with sonography, that is called a FAST examination, is positive for free fluid in the right and left upper quadrant. His pelvis is mechanically stable. The peripheral neurological examination is normal. He has had no past medical history, takes no medication, and has no drug allergies. So what do you do in such cases? That is very simple. As per the protocol, your team, you will approach to the patient in the following sequence. You will first intubate the patient, expecting poor clinical course.
Okay. ఖాళీ ఈ రోజు పెట్టారు మార్నింగ్ 6 కూడా మళ్ళీ 2 o'clock 3:30 చేస్తారు మళ్ళీ 4:30 చేస్తారు అప్పుడు అన్నిసార్లు రిజల్ట్ వచ్చేటప్పుడు కొద్దిగా ప్రెజర్ పెట్టినప్పుడు ఇట్లా బీపీ పల్స్ బాగున్నాయి
అలా కాదులేండి అలా కాదులేండి ఆక్సిజన్ శాతం చాలా తక్కువగా ఉంది 100% ఉండాల్సింది 67
You do the chest replacement, blood transfusion administration, and 1 to 2 liters of fluids, infusion at initial bolus, and then send the patient for imaging and CAT scanning. Now, as soon as you intubate the patient, what happens? The blood pressure drops to 60 systolic. Suspecting a tension pneumothorax, you do a needle decompression and another liter of crystalloid for the shock. The systolic pressure does not rise till blood products are administered and tranexamic acid is given. He shifted to the radiology department for a CT where his pressure drops again and more bloods and fluids are given. He is diagnosed with a frontal hematoma with right-sided pneumothorax with liver and splenic laceration. What you need to remember now, trauma care goes beyond the guidelines of the ATLS. The guidelines are exactly what they are, guidelines. They are least, minimum one should know regarding trauma management. Emergency medicine and trauma care are like the rails running parallel to the sleepers or guidelines. Unfortunately, in a lot of places and practices, ATLS guidelines are followed very rigidly and the vastness of trauma care gets forgotten. So you need to understand what is ultimately your goal. What is trauma resuscitation all about? You need to ask yourself, is it about keeping your patient alive? Is it about minimizing pain? Is it about quicker diagnosis? Is it about critical action? Is it about disposition and transfer? Remember, time is of the essence, but also remember, some may not have serious injuries and you might have all the time you need, but you still got to rule out time critical injuries before you take a sigh of relief. There will be a lot of things going on in your head and they may as well be haphazard, but you have got to think of your top goal. What comes first? Now, to understand this, I would like to tell you something about trauma resuscitation. It's a complex and intricate process involving multiple team members, or sometimes just one or two, but with various roles, simultaneous evaluations, examinations, management, and disposition in a coherent manner. The different teams team members will have different roles, and management of different cases will be different. Evaluations will be very, very case dependent. Examinations, you have to go to do your examination. Disposition, it is all these things require a lot of coordination among the team, and a team leader has to be a very, very perfect person in doing this. So this is where I tell all of you, I want to tell you all of you, like, some people believe trauma might be easy, but trauma team are hard. Managing trauma might be easy, but when trauma team is there, it's very, very difficult, and it's very hard to get along with everybody at the same page in the same line. According to the shared mental model theory, a trauma team's performance is optimized when team members have a common understanding of the team and task requirements without the need for explicit discussion. The system has to provide seamless care for the trauma patient, one step to the next. It is better to individualize your care to what each patient needs, because the needs of different patients will be very, very different. It cannot be every time same. So this when one thinks that this is the goal and end of all. I faced this issue with trauma teams, multiple times, where some other specialists believe ABCD of trauma surveys is what trauma is all about, which is not right because your goals are different. So now, before the team gets together or move forward, remember, trauma patients are very dynamic. Your whole ED becomes dynamic. They get supercharged. There would be chaos. It feels like everyone is on cocaine. If not, they should be. So airway evaluation is always necessary as soon as a trauma patient arrives to the emergency. But unlike ATLS paradigm of airway management first and then correct the rest, you have to understand, okay, agreed, airway has to be managed, but now you have to understand when not to, rush towards the airway management. The new approach varies slightly, but is of utmost importance. The definitive airway should be established first only if there is critical hypoxia, which is not responding to high flow oxygen, and supportive maneuvers, or airway has dynamic injuries like blunt, penetrating, and blunt injuries to the head, neck, or oropharynx that might compromise oxygenation, ventilation, or airway management, and there are suspected to worsen, and the airway is suspected to get worsen on a very short time. Then only you have to rush for the definitive airway management. Otherwise, initially first provide with oxygen and approach to the other cases, other injuries, whatever is there. Now, intubation causes, if you rush for the intubation, what will happen? It will cause an increase in the intrathoracic pressure, resulting in a decrease in right atrial pressure. Where patient is already hypotensive, the reversal in intrathoracic physiology following intubation compared with spontaneous respiration will have a significant impact on the shock states that are common among patients with trauma. In hemorrhagic shock, what will happen? Patient is already in shock due to low venous return, can decrease further with positive pressure ventilation. Pre-intubation hypotension is a significant risk factor for post-intubation cardiac arrest, highlighting the importance of adequate volume resuscitation before intubation. What happens in obstetric shock? Say, for example, tension pneumothorax or cardiac tamponade. This decreased venous return and may also be worsened by positive pressure ventilation. You have to focus intervention to relieve obstructive causes. Obstructive causes has to be relieved before you consider, intubation in order to optimize hemodynamic and, establish safer pre-intubation and post-intubation conditions. In summary, only a small percentage of patients, I would like to say, who as a trauma victim who comes to the ED with require definitive airway management immediately on arrival, as they would be having some critical hypoxia and dynamic airway. Instead, most patients from aggressive resuscitation, before intubation are benefited. Intervention include those that stay hemorrhage, optimize perfusion, and relieve obstructive shock causes. Once these interventions are initiated or completed, then definitive air management can proceed. Now, decision to intubate in a shock, very, very critical thing and very complex. You need to understand sometimes that current hemodynamic status, will the patient tolerate a further delay to intubate in an effort to optimize hemodynamic? If you think of him, like these are questions you need to answer, whether the patient can wait to be intubated. So you need to look at the hemodynamic status. Say, for example, if the patient requires blood products, administration, etc. Facilitation of resuscitation, very, very important thing again. Is the patient unable to safely tolerate further procedures? Say, for example, bag mask, ventilation, pelvic binder, venous access, without intubation. Project course, like what does it mean? That are there indicators that delay airway intervention will complicate the procedure later during the resuscitation? And of course, over and above all, clinical cholesterol, the clinical experience of the clinician should not be underestimated. In certain instances, there may be a combination of multiple factors that individually may not be sufficient to warrant intubation, but together necessary definitive airway control. If intubation is not required, then the trauma team can proceed with a plan towards definitive care. And all these things will be dependent on the trauma team, the clinical expertise, the clinical gut feeling, what you see from inside and what you feel inside. It is not about, yes, this is written and this has to be done like that because the guidelines or the ATLS says like that. This you have to understand what shock or occult shock is. Shock is a clinical state defined by circulatory failure resulting in insufficient cellular oxygen use. And it manifests with clinical and hemodynamic derangements. Occult shock can exist if these obvious clinical disturbances are subtle or absent despite underlying hypoperfusion. So it is very important to understand whether the patient is in shock or in the occult shock, because this is going to change. This is another very important slide for everybody to understand. Traditionally, as an ED physician, what we have been learning and applying through the ATLS shock classification to predict the amount of blood loss. Class 1 has 750 ml of blood loss, class 2 has 750 to 1500 ml, class 3 has 15 to 2 liters, and class 4 is more than 2 liters and all those things. But the widespread application of the system has occurred without any formal study or validation. If you look at these study of a German trauma registry showed that only 9.3% of the patients with trauma can be properly categorized according to ATLS shock classification. Then there was another audit of in the UK trauma registry from 89 to 2007 patients progressing to stage 4 shock, where that means the blood loss should be more than 2 liters and the heart rate should be increasing, patient should be becoming tachycardic and all those things. But you see in this study, it was shown that the heart rate increased only from 82 to 95 while showing no significant changes in GCS, respiratory rate or systolic blood pressure, even though patient was in grade 4 shock of more than 2 liters of blood loss. So you see, every time all these classification of shock, what we have been following is not necessary that the patient is in grade 1 shock, class 2 hemorrhagic, class 3, because we assume maybe sometimes the patient might be in grade 4 shock, but the vital signs and other things are not giving us the clue, and they are absolutely looking normal to us as they would have been in class 2 or class 3 shocks. So what is important? Challenges exist in the early identification shock in patients with trauma. So variable pathophysiologic and compensatory mechanism produce a range of hemodynamic presentations that complicate assessment. During the initial resuscitation period, the indices of a shock identification can be organized into 2 broad categories. Clinical indicators, obviously, which we as a clinician feel it can be obtained exclusively on the bedside, and the second one is lab indicators, which is additionally lab testing is required. So coming on to the clinical, what the clinical indicators what we see as the shock index, besides ultrasound, sometimes not reliable, patient might be, like we are feeling the patient is getting the systolic blood pressure of 100, but might be little low. When the lab indicators, but the, like shock index and bedside ultrasound are more predictable. In the labs, which we see like base deficit, lactates, and electricity assays like ROTEM and TEG, which is also a good lab indicator. So now an assessment of trends in vital signs. Adequacy of peripheral perfusion, the physical examination findings, can yield a more accurate estimate of the presence and degree of shock during the primary survey, compared with blood pressure or heart rate alone. So now the shock index, it is defined as, the ratio between the heart rate and the systolic blood pressure is defined as shock index, which is a simple and reliable method for estimation of degree of shock and predicting clinical outcome in a variety of settings, including trauma and variety settings. Like in trauma resuscitation, we do use it at quite a level. The shock index is useful in trauma because of its simplicity, strong inter-rater reliability, and accuracy as a predictor of blood loss. A value of greater than or equal to 1 is associated with significant increase in transfusion requirement. Increased severity, injury severity, of course, increased injury severity and mortality. FAST is a standard part of the evaluation of patient with trauma. The extended FAST, that is eFAST, includes an evaluation of thoracic structures for pneumothorax and hemothorax. And there's a growing evidence that the eFAST is a superior diagnostic modality to supine chest radiograph for detecting pneumothorax. And obviously we know the signs when we do the eFAST. So now let us see what is the role of base deficit and lactate in shock to identify the shock or the occult shock. In trauma, base deficit closely correlates with transfusion requirements, injury severity, and mortality. It is particularly valuable. It is particularly valuable during the initial phases of resuscitation because an increased base deficit can help identify patients who will, sooner decompensate. A recent systematic review that concluded that base deficit greater than 6 is useful for prognostication and also to guide resuscitation in patients with trauma. On the other hand, lactate also be useful as a surrogate predictor of blood loss. An increased lactate level measured shortly after injury is widely accepted as a predictor of shock and mortality in patients with trauma. Let us see another fresh from the oven, TEG and ROTEM. TEG is what? TEG is thromboelastography and ROTEM is rotational thromboelastometry. Generally, we know on arrival in the ED, about 25 to 30% of severely injured patients are coagulopathic, and they will fail to form adequate clots in response to hemorrhage. What happens? Standard coagulation tests are inadequate, what we do in our ED, to identify clots because they only identify early phases of clot formation. Now, 2 point of care viscoelastic assays have emerged as promising alternatives for early coagulopathy detection in trauma. They are these 2 things, thromboelastography and the rotational thromboelastometry. There is no single indicator that can reliably predict both the presence and degree of shock for all patients with trauma. Combination of indicators should be integrated into clinical decision making in a systematic and measured fashion, with your clinical expertise and experience to understand the type and degree of shock or the grades of shock and act accordingly. We know we have to keep our patient alive. We know we have to do the damage control resuscitation, blood and no crystalloids, Get your tranexamic acid in, allow permissive hypotension, give some calcium. You want to avoid the lethal diamond, or if they are already in it, they try and mitigate the effect. There are still people who will, when you are doing resuscitation, you'll come down from upstairs, who will question you, why give blood and not fluids? Only ask them to please go and get updated. Stop the bleeding. Where is the bleeding? What solution can you use? Maintain coagulation, push tranexamic acid, push the patient to the OT, plan ABC. And on this, I would like to give a very good example of the milkshake paradigm. Recently our team has come up with this idea that what is milkshake paradigm. I'll give you a very simple example. You are doing a party at your home. You invite few guests at home, and you had given invitation to 5 people, and you have prepared some milkshake with good amount of milk and other ingredients of cashew nut and all those things, and good quality milkshake you have prepared for 5 people. What happens? Another 3-4 people join into that party. So now what are you going to do? You have only 5 glasses of milkshake and you have 8 people. Are you going to dilute it with adding water into it and give it to the 8 people? Answer yourself. This question is for all of you to think and answer. If you think you will dilute and give, that can be a way, but do you think now the quality and the essence of the milkshake will remain the same as it was prepared for the 5 people? No, it will definitely reduce the essence, the beauty, the taste, everything will vanish. So what is the best way? Either you add more milk, more cashew nut, more ingredients, and make that 5 glass into another 8 glass. Or that is the best thing to have a pleasurable thing. Similarly, when the blood is lost, why to give fluids? The replacement of blood has to be blood, nothing else. So remember this milkshake paradigm. This is very, very important. When somebody comes from up and asks you, why are you giving fluids? Why are you giving blood? You're not giving fluids. Most of the time you will have these discussions in your department when you're trying to give, transfuse blood to the trauma victims in emergency shock. So many studies have shown that there is no perfect agent for induction. This is also important when you are intubating the patient. Although, we recommend ketamine given, its overall favorite with overall safety profile. When the patient is in obvious or occult shock, the induction dose, only remember, just reduce it to by 25 to 50%. But for prophylaxis, the full dose of the neuromuscular blocking agent is recommended. Even the larger dose of the neuromuscular blocking agent can be given, but the induction dose has to be reduced by 25 to 50%. This is very important when you are going for the definitive airway management in a patient with shock. There are many pitfalls, it's all written in the ATLS book. I'm not going to talk about this, but few like reliance on ATLS shock classification, in resuscitation of decision making, apply evidence-based clinical indicators to identify shock and occult shock, unrecognized signs of shock, strict application of ABC paradigm. So there are pitfalls, there are mitigation as per the ATLS. So you can always have a look and go ahead with it. Before I take your permission and say you bye, I just want to end with few thought to be carried out, taken home with you. Always, have a good shared mental model within the team, which is going to play an important role as to how the incoming trauma patient will be handled in your ED. So have a common goal, common understanding, and common way of approaching, and always have a platform where you have mutual respect and discussions of the cases. Trauma does not only start and end with ATLS. Please remember this. Trauma is much more than that, and never forget that. Think beyond ATLS and modify your plans accordingly. Go for the definitive airway as first step in times of where you have a patient with critical hypoxia or not responding to your normal adjuncts like oxygen or other airway adjuncts, or when there is dynamic injuries to the head, neck, and face. At other times, always attempt to resuscitate before you go ahead and intubate your patient. Next, what I would like to again, focus on, always look for signs of occult shock. Always look at shock index and remember to reduce the induction dose when intubating the shock trauma patient, because that is very, very important. Airway management in trauma patient is in itself is a big challenge, and you need to be very, very careful in these things. And please do not forget what I've told you, the milkshake paradigm. This is very, very important for you to be confident while resuscitating a trauma patient and answer your other specialties when they come and ask you why blood, why not fluids. And most important thing, I would like to tell you before I leave, you are the king of your team. Always remember that. Own your trauma patients. Because until unless you feel the king at the floor and own the patient, the right thing for your patient will never happen. Thank you very much. I would have loved to take your questions directly today, but I'm sorry, as I've already requested Dr. Rajat Durai, that being Shivratri of this Sawan Mahina, we have a big puja at home with all family members in. But even then, if I get an opportunity, I will definitely quickly log into, or I'll make sure somebody on my behalf is thank you very much. Namaste. Have a great day. Looking forward to have you all in Delhi on 11th August. We are going to do and other, even not only emergency medicine, as the first green conference of in any country in the healthcare industry. So the conference country, they will be giving and sharing their best practices, what they do in their emergencies, and I'm sure a lot of us will be learning from each other and becoming better in whatever we are doing today, because we might be the best, but to continue towards the excellence is a great journey. And in this journey, Dr. Raja Durai and SEMI National Board has taken this initiative of series of lectures, and I really thank from the bottom of my heart to all the participants and the organizing committee for this series of lectures. Thank you very much, Raja Durai, and everyone. Have a great day. Thank you very much.